All right, so we'll get started. Thank you for joining it today. We have an interesting grand rounds, and to get started with today's proceedings, we'll just go through the initial process of getting the CME activation and the MOC activation. So again, the website becomes stronger and stronger with some outstanding contributions from leaders nationally who have contributed to a list of different ground speaking engagements. The CME credit for this session, please go ahead and text 20379 to the number 888-816-4893, 20379 888-816-4893. And for having an MOC for physicians, please complete the step 1. And this link again will be displayed in the chat box. So use this link, which will be available and active for 12 hours, and use the room code future53 to gain your MOC points. If you correctly address all the questions, it will go directly with your ABIM Cloud CME profile. So step 1 is the CME 20379. And then the step 2 is to do the MOC point with a link. All right, so with that, I'm actually very happy to introduce for today's grand round, Dr. Mohammed Alomar. Mohammed, welcome. Dr. Alomar is Assistant Professor of Medicine, Chief of Section of Cardio-Oncology, Director of the Cardio-Oncology Program at the Mersani College of Medicine, University of South Florida. He's the director of the Cardio-Oncology Program, also at the H. Lee Moffitt Cancer Center and Research Institute. So just before anybody would wonder, how did I come to know Dr. Alomar? Well, I did the same thing that I've done for many people using social media. So I saw him very active on the social media, and I did not hesitate to connect with him and try to understand what exactly his role in cardio-oncology was. And I was very surprised. So the text message went right from the Twitter account. I didn't have any other connections. If many of you know about how to get through Twitter to directly be able to connect with the person, that's one of the easiest way to get to someone who's enterprising and really interested to connect with you. So, and then we connected on a phone call, and I came to know that I think he has done a great job in establishing a career in cardio-oncology. So to briefly mention his origination was, I looked through his CV, was from Baghdad, Iraq, but he started as a medical interpreter and cultural advisor in the United States Armed Forces. And then subsequently, his enrolled to medicine. He was in Icahn School of Medicine at Mount Sinai, at Englewood Hospital Medical Center. He completed his residency and then his fellowship in cardiology at Newark Beth Israel Medical Center at New Jersey. So right here. And subsequently, he did a fellowship in cardio-oncology at University of South Florida. And what I came to know was that he's been very entrepreneurial and enterprising to engage the leadership there and create a very high working, high throughput cardio-oncology program. And he's been really successful in not only doing that, but also developing a dedicated fellowship program. He has a wide interest in several cancer medication that can impact the heart, and he's doing a lot of nice investigation. He's got over 24 peer-reviewed publications, and I think he's one of those early career physicians who's bound to make an impact. So I invited him to make us more aware, and today I think he's here to provide a unique lecture on some of the emergencies or acute presentations in cancer cardiotoxicity. With that, Mohammed, welcome. And I'd like to also bring on our panelist, Brandon Overweis, who's really interested in cancer cardiotoxicity. Brandon, welcome. And also Sasha East, who has been taking a keen interest in multitude of different scenes, but obviously he's been following a lot of patients with cancer cardiotoxicity. So Sasha, welcome. So you will be both back with us on the spotlight for the discussions at the end. So with that, Mohammed, I'll invite you to give your presentation.
Thank you, Dr. Sengupta, and good afternoon, rest of the faculty. I appreciate the invitation. You're very kind. It sounds much nicer when you read it out, the accomplishments, and certainly I appreciate the kind invitation here. So let me just share my screen. Not this one. Just 1 second. And want this. Can you guys see my screen or no?
We can see you. This looks better.
Perfect. Alrighty, so we'll talk about cardiac complications of emerging cancer therapies, and the list is long. So I chose 2 topics really thought there would be high yield in your clinical practice that you might see. I have no conflict of interest regarding this talk. These are our learning objectives today. The basic definitions and mechanism of actions of immune checkpoint inhibitors and chimeric antigen receptor T-cell therapy, so ICIs and CAR-T going forward. We're going to recognize the associated cardiac complications and discuss the management principles of the potential adverse cardiac events. And just to remind you how oncogenesis happens, basically for cancer to start and grow inside the body, it has to escape the body's immune surveillance systems. All right, so the immunotherapies that we have that are approved right now work really by one of 2 ways, either by provoking a de novo anti-tumor response or by reactivating an immune response that has become ineffective and that the cancer cells have taken advantage of. The therapies that you'll see, whether it's infusions, whether it's advanced technologies, typically rely on one of these to target the cancer cells and provide the anti-tumor response. And you've probably seen a lot of these immunotherapies as they come on the market and how they change the face of oncology and the prognosis of these patients. So part 1 will be immune checkpoint inhibitor talk, and then we'll talk about CAR-T later on. Let's start with this case. This was a nice 80-year-old man who was diagnosed with metastatic renal cell carcinoma. He had a left nephrectomy and came to the oncology clinic afterwards for recommendations. He had coronary disease, PCI, last in 2010. I saw this guy last year, so was 12, 13 years after his PCI. I never had any angina or any other episodes after that. Hypertension, hyperlipidemia, and these were his medications. All right, so his oncologist started him on axitinib and pembrolizumab. One thing I learned to recognize in cancer is if there's something that ends in MAB, Google it, make sure it's not an immune checkpoint inhibitor. So I think I always say 1 year of cardiac oncology really is good enough just to kind of tell you how to pronounce this stuff and see what they are. And then you learn on the job after you graduate. So axitinib is a tyrosine kinase inhibitor. It's a vascular endothelial growth factor receptor inhibitor. Pembrolizumab, Pembro, is sometimes they call it Keytruda. You may see commercials on it. That's a monoclonal antibody that's an immune checkpoint inhibitor. So he started that in 2022. In November 2022, he presented to an outside hospital for a syncopal episode. He was found to be in a 3rd-degree AV block, and I presume no new left bundle branch block. His troponin high sensitivity at the time was 1900. The upper limit of normal is about 1415. Because it's high troponin, new left bundle, he went to the cath lab. He had no chest pain at the time, and he had a heart cath, basically total occlusion CT of the LAD with right to left collaterals. Nothing acute to explain the new left bundle or the high sensitivity troponin, so no interventions were done. and echo at the time showed a normal ejection fraction. We'll come back to this case in a few minutes. If you've been monitoring this, there are a lot of talk about the immune checkpoint inhibitors when they started to come around, and this was one paper, one article that in New York Times that looked at how effective these were, and basically they work on enhancing the body's immune system, its own system, to fight against cancer. So it's unlike chemotherapy, where kind of the equivalent is like a nuclear bomb, if you will, like it targets a lot of cancer cells and healthy cells. These checkpoint inhibitors really just poke the patient's own immune system to fight against cancer. It has the ability to do that. It just couldn't recognize cancer cells, and these medications enhance the patient's own cells to recognize cancer and kill it. And they have been instrumental in treating cancers. The list is very long, but the ones that are commonly used: melanoma, renal cell carcinoma, and then small cell lung cancer. Rising Carter in, I believe, 2015, 2016 perhaps, when he was diagnosed with melanoma. At the time, it was really a deadly diagnosis, especially if it has metastatic disease. And his cancer did very well on immunotherapy. So this was him giving an interview afterwards. And there's just a simplified algorithm to tell you how it works. So on the left side here is a patient on no immune checkpoint inhibitor. So basically, this is a tumor cell. This is the T cell. We all have these receptors. They call them programmed death. So programmed death appears on the T cell. The ligand typically is on the tumor cell. The tumor cell engages the programmed death receptor on the T cell to inhibit the T cell's recognition of the cancer cell. Okay, so once this interaction occurs, the T cell does not see that this is a tumor cell and just moves on. So if we take advantage of this interaction with an immune checkpoint inhibitor, so these are all checkpoints. They're all they're there to help T cells recognize bad cells that could be tumor cells or could be other native cells that went bad, and basically enhance the cell's suicide, if you will. So when this interaction happens, the cancer cell does not have any consequences and just moves on. And the T cell does not recognize it, does not kill it. If you have these checkpoint inhibitors, like an anti-PD-L1 or anti-PD-1, you're basically allowing the T cell to recognize the tumor cell, and that's how the tumor cell dies. So, and there are a couple of other receptors that we have immune checkpoint inhibitors for, and basically does the same principle. So the principle is allow the T cell to recognize the cancer cell and kill it. And the two scientists, Jim Allison from MD Anderson and Dr. Hongo from Kyoto University, got a Nobel Prize in 2018 for their discoveries of this immune checkpoint inhibitors. And of course, there is no free lunch. So whatever there is effect, there's side effects. So people start to recognize this early on, and devastating cardiac side effects occurred. And that's why we're talking today about this. There are anti-CTLA-4, there are anti-PD-1, anti-PD-L1, anti-LAG-3. So there are tons of receptors that are targeted for this effects, basically. And the data on these immune checkpoint inhibitors, it's almost like every week you hear something that there's a new either immune checkpoint inhibitor diagnosis or action. So typically the list of indications for their use becomes bigger with time. And the side effects are common. Actually, the majority of the side effects are non-cardiac, and the majority of the cardiac side effects are not deadly. So we have a lot of arrhythmias. We can see accelerated atherosclerosis, but things like myocarditis are usually the more deadly ones, and that's why we kind of tend to keep that in when we see an ICI, even though most of the cardiac side effects are really not myocarditis. So this could be AFib as VTs, VT, heart blocks, and typically these two, ventricular tachycardia and heart blocks, occur in the setting of immune carditis. But we see pericarditis for pericardial effusion, not always tamponade. You can see arteritis, vasculitis, and heart failure, and Takotsubo. So really it comes in a lot of forms. The incidence of the cardiac toxicity really depends on how good and how well you look. So if you look hard enough, you'll see a lot of these cardiac side effects. This one study looked at 25, or I think it was a little bit more actually. There was 140 patients, 25 of them had myocarditis, and there were a lot of cardiac events depending on how you diagnose it. So arrhythmia is pretty high. Cardiomyopathy happened in a lot of patients. Some of these are double counted, so that's why the percentages appear large. It turns out these checkpoint proteins are really helpful in other things. So beside killing cancer cells and killing other senescent cells, they have a lot of regulatory effects in terms of atherogenesis. This was a very nice review from Giselle Sorabru, who's now she's a cardiology fellow at I think at the Mass General, published this recently. It tells you all about the targets of these immune checkpoints that have favorable regulatory effects to prevent atherogenesis. So when we do use these immune checkpoint inhibitors, we tend to see accelerated atherosclerosis. And I think in 5 to 10 years from now, as we become more aware of this, we'll probably start dealing with atherosclerosis more than we deal with the myocarditis right now, which is one of the most feared side effects or complications. Myocarditis happens at about 1%. I think it is underreported, underdiagnosed, but this is what's published out there in the literature. Typically happens at a median of 34 days. For most patients, that usually correlates with the second cycle of their immunotherapy. Most of these are usually every 2 to every 3 week cycles. So usually 34 days is the median time to presentation. But late events have occurred, and we can see this up to 6 months after the last dose of ICI. Some patients continue to receive immune checkpoint inhibitors for life, especially those with metastatic disease. So they may get an infusion once every 3 weeks, once every month, and they basically remain in some kind of a remission. So it's kind of a turning a deadly metastatic disease into a more of a chronic issue. So that's why it's important, really, when you make a diagnosis of myocarditis, to kind of we want to make sure we don't label it and blame it on the ICIs, because that could be a death sentence for a lot of patients. Okay. Most of these events are okay, but the mortality rate that happens with myocarditis is pretty high. So especially if it goes underdiagnosed or undiagnosed for some time, it can really progress into fulminant myocarditis. When that happens, it has a mortality rate of up to 50%. Typically, when you do myocardial biopsy on somebody with immune checkpoint inhibitor myocarditis, you'll see something like you see with a lot of viral syndrome. So a lot of lymphocyte infiltrations. And when you do certain staining, you can see the CD4 and CD8 cells, the T cells. And if you ask your pathologist, if you're unsure about the diagnosis, you can ask for staining for programmed death ligands, for example, like in this case here. That kind of confirms that this is actually an ICI-related myocarditis and not something else like COVID or flu or something else. And the degree of symptoms really vary from what they call grade 1. These terminologies are used commonly in the oncology world. So grade 1 typically, when it comes to ICI myocarditis, is abnormal cardiac biomarkers or EKG without a lot of symptoms. Typically, grade 5 is death. Grade 4 is something that's life-threatening. So our patients that we discussed certainly had a grade 4 life-threatening condition with that complete heart block. Alrighty. The majority of patients with ICI myocarditis come in with normal ejection fraction. So when they come into the emergency room the first time, for maybe a little bit of elevated troponin, some non-specific symptoms, you do what you do to rule out coronary disease, and comes back negative, whether it's cath or coronary CTA, and get an echo, about 50%. That does not mean they're out of the woods yet. They could still have myocarditis. And we think those who actually come into the hospital with low ejection fraction may have had myocarditis for quite some time. So by the time they, have low ejection fraction, they probably have had it for a long time, or just started with a very severe case of myocarditis. But the majority of cases come in with some mild symptoms, abnormal biomarkers, EKGs, and a normal ejection fraction. The way we manage these basically is the recognition. So the recognition is really half the battle there, because once it goes undiagnosed, the next time you hear about the patient is usually when they're in cardiogenic shock. So our fellows know when to suspect this is to start immediately treating it as if it is ICI. Of course, the more common things remain the more common things, which is coronary disease. So if you have the right patient demographic, middle-aged man, women with coronary disease risk factors, yes, get your troponins every 4 to 6 hours. If you have the high sensitivity, perhaps even sooner than that, and rule out coronary disease. But we typically do not wait to confirm the diagnosis to start management of ICI myocarditis. So how hard you go with the treatment depends really on the severity of symptoms and biomarkers. So typically for grade 1s, usually we continue ICS, maybe hold it for a cycle or two until the biomarkers improve, and continue supportive care. If you read JACC Cardio-Oncology and some of the cardio-oncology literature right now, especially after late last year, you'll see the term permissive cardiac toxicity come a lot. So basically, this is where we know there is a cardiac side effects from this particular cancer therapy, but we're allowing it to continue with certain surveillance to allow patients to continue to receive a life-saving treatment. We do this in particular for those who have no good alternative. And a lot of patients who get ICIs typically have no better alternatives. But that's certainly the time to pick up the phone, call your oncologist and say, hey, we have a problem. How good are the alternatives here if we're going to stop this therapy? So for grade 1, typically, maybe we'll hold for a cycle or two. We'll continue ICI, and typically with close monitoring. Usually that means a troponin before the next cycle, and there's significant elevation. We usually continue to hold, perhaps treat with corticosteroids. Grade 2, 3, and 4, depending on who you ask and the alternatives that are available, we may withhold ICI temporarily or withhold it permanently if there is some kind of an alternative. Typically, we start corticosteroid for those patients. Okay. Grade 4 patients are usually the ones who will absolutely have to be in the hospital. Sometimes we manage grade 1 patients as an outpatient. They have no symptoms, their EKG is stable. It's just a surveillance biomarker, basically elevation, that's it. And so the severity really of the immune-related adverse event dictates the urgency and the strength of the recommendation. This was a nice algorithm that published 2019 in JACC. Typically, what we do, the first thing for these patients is usually high-dose steroids. So that's usually a gram a day. You can divide it 500 Q12 if you want, with peptic, ulcer, and glucose monitoring, and monitor them on telemetry for arrhythmias, and of course, get an echocardiogram. If we do not have the right response right away, and that's usually defined as 50% or more drop in troponin in the first 24 hours, that means you need something else that's not corticosteroid. And it's really, the recommendation right now is based really on expert consensus. We have no randomized data that tells you if steroids don't work, use this. So there's a lot out there. So there's mycophenolate, infliximab if you don't have heart failure. ATG is one of these things that have been used, again, based on case reports, and abatacept. Alemtuzumab, I think, was used also a couple of times, but really, after steroids, it's just whatever you're comfortable with. This is the time to talk to your heart failure guys, especially those who deal with cardiac transplant rejection, and use their protocol. Because really, beside the steroid protocol, we really don't have a lot of data to tell you what's best. Other biomarkers that we use typically are CPK and LFTs, because usually when there's myocarditis, there's something else going on. So typically, if somebody comes in with, let's say, nephritis or hepatitis or pneumonitis, we usually ask our teams to let us know right away to screen these patients, because infrequently you'll see myocarditis at the same time as pneumonitis or nephritis. The treatment might be a little different, even though for the majority of these other organs, typically the first day or two, you're going to be using high-dose steroids. Our patients basically was given high-dose steroids. They called us. We made the recommendations, and unfortunately, the patient ended up getting a pacemaker before they get their cardiac MRI. They could not do a cardiac biopsy at the time. But looking at his coronary angiogram, looking at the other chemotherapy or targeted therapy he was exposed to, the most likely diagnosis was the ICI myocarditis. And we started noticing his troponin go down quickly after steroids. So he got the high-dose steroids for, I believe, 5 days. You can do it anywhere between 3 and 5. Was discharged home, and on 1 milligram of prednisone, 1 milligram per kg per day over 6 weeks. By the time I saw him in the clinic, his troponin has been normal, and he basically was in remission, stayed in remission since. We don't know if the heightened immune response that the patient got that ended up leading to him getting myocarditis was also highly effective in putting him in remission. We seem to, at least we like to think that, but he only had 2 cycles at the time, and he was, I believe, he was prescribed for 5 cycles, and he was in remission and stayed in remission. But we did make a recommendation that he permanently discontinues it because the immune reaction he had was dramatic. So if, God forbid, he goes into relapse, they will have to find him another option. I have to bring this to your attention. The Atrium trial is really the first investigator-initiated, randomized, double-blinded, placebo-controlled trial that will use abatacept versus placebo in those with ICI myocarditis who are in the hospital to see if abatacept works. The study is active at your hospital right there. So if you happen to have a patient who might fit the criteria, please talk to your leadership and connect with your oncologist, because I think this will be a worthwhile effort. We have it here. We're enrolled 1 patient. I believe you guys have a 1 patient enrolled already, or maybe not. But abatacept has shown some promise in retrospective case reports and studies, and some animal studies, and it's a CTLA-4 antagonist. It's used for rheumatoid arthritis and graft versus host disease in patients with bone marrow transplant. So we think it's promising, and we can really look forward to this in the next 3-4 years. I think we're up to 25 or 30 patients enrolled so far. I think we're looking for 400 patients. So the primary endpoint of the study will basically MACE. There's some secondary analyses that we'll be looking for, including troponin. Remember this study if you think of a patient next time with ICI myocarditis. So with that, I'm going to start with the next part on CAR T. If there are any questions, please feel free to stop and ask. But the next therapy that we're going to talk about here that I think you'll probably see and hear about will be the chimeric antigen receptor T-cell therapy. Different indication, different set of complications, but nonetheless can be deadly. And we're going to start with this case of a 69-year-old man with stage 4 mantle cell lymphoma. He had a history of type 2 diabetes, hyperlipidemia, paroxysmal AFib. Unfortunately, progressed with his lymphoma despite multiple lines of treatment, including lenalidomide and rituximab. So he was admitted to Moffitt to undergo Tecartus, anti-CD19 CAR T therapy. On day 5 of the therapy, he developed cardiogenic shock, distributive shock picture, had pulseless VT and VFib. That was consistent with what we call grade 4 cytokine release syndrome. So the next few slides, we're going to talk about this therapy, what CRS means, what to look for, and how to assess these patients. This is a very intelligent and really important, I think, feat in terms of how we treat cancer. That's really promising, and it really tells you how amazing these biomedical engineers are. What we're doing here in this therapy basically is taking modified T cells that we're going to give them back to the patient to destroy cancer cells. The patient basically has cancer. We know that their T cells are very smart in recognition of cancer, so we just really need to enhance their ability to recognize the cancer in the patient's own body. So we take these T cells, send them in the mail to either California or Maryland, wherever these commercial CAR T cells are, makers. What we do is they inject these T cells with a vector, typically a benign virus, that has a particular genetic material with instructions to make this CAR, which is the chimeric antigen receptor. Okay, so the cells go into the the virus goes into the T cell. The T cell machinery will take up the genetic instructions from the virus and start making a protein called CAR. That's what we call a CAR T. This receptor is designed to target that particular cancer cell. So if it's a lymphoma, typically it's an anti-CD19 receptor. If it's a myeloma, it's an anti-BCMA receptor. So basically, you want that T cell to have tons of these receptors that will recognize the cancer cell. Okay, so that's why they call anti-CD19 or anti-BCMA CAR T therapy. You wait for these T cells to grow in the labs for millions and millions. And when they're ready, you bring them back and you infuse them into the patient. Okay. Before we infuse them back into the patient, we give the patient some kind of lymphodepletion therapy. It's not intense, but it's some kind of a chemotherapy that will basically make some kind of immunologic space for these new T cells. We want to get rid of some of the old T cells that are not as good. They don't have these receptors. We want to make room for all of these millions of the cells inside the bone marrow, and then give these cells. So once these cells go into the body, they're still really going after the T cells. And since they have so many receptors on their surface, they're going to identify a lot of cancer cells for us. So very effective at treating cancer. Of course, if it's effective, it's going to have side effects. So the issues that happen with these CAR T cells can be threefold. There's what we call the on-target, on-tumor effect. So this is one mechanism of cardiac side effects, meaning the T cell is doing exactly the right thing. It's going to the right receptor on the right cancer cell. But because there's so much cancer cell killing and cancer cell death, the contents of these cancer cells leak into the circulation, causing what we call a cytokine release syndrome. We're going to talk about this in just a bit. There is another way of causing cardiotoxicity here, which is typically that we call it the on-target off-tumor effect, meaning the T cell is going at the right target, at the right receptor, except it's just not a cancer cell, it's just a normal cell. It could be the heart, it could be the kidney, it could be the liver. And there's, of course, the total failure when it's called off-target, off-tumor effect, meaning the T cell goes to exactly the wrong target, receptor, the wrong organ, and cause a problem. Typically, we don't see this. Usually, this lasts 1 year. When there is an off-target, off-tumor side effect, typically the FDA is not going to approve this for us. So typically, most of the issues we see are the first two. Cytokine release syndrome is really not just a CAR T issue. It can happen in a lot of other conditions. Typically, a lot of inflammation, usually characterized by fever and something else, either hypotension or hypoxia, and typically some kind of end organ damage or toxicity. They grade it based on the severity from grade 1 to grade 5, grade 1 being just a little bit of issues, but no symptoms. Grade 5 is death. It seems like most of the cardiac issues that happen because of CAR T happen in those with grade 2 or higher. One of our fellows, they published a couple of papers on this, and it's pretty clear that patients with grade 2 or higher usually have these cardiac side effects. Lower grades typically don't have this. So the issues that we have with cardiotoxicity from CAR T usually happen because of CRS. Sometimes these lymphodepletion therapies that we gave the patient right before the CAR T can have cardiac side effects. Sometimes if there's a cross-reactivity between the CAR T and the muscle cell, you can have direct invasion of these CAR T cells into the myocardium, and that can cause issues. And this can range from sinus tachycardia to any arrhythmia. So atrial arrhythmia is pretty common, up to 15%. But we have seen heart failure, usually because of myocardial stunning, some form of Takotsubo, to vascular leak syndrome and circulatory collapse. One bad CAR T side effects happen that can be very dramatic and they progress very quickly. There are some considerations when it comes to the cardiac management of these patients. So usually we see these patients before CAR T, and now after the 2022 European Society of Cardiology guidelines on cardiac oncology, our life's gotten a lot easier in terms of initial screening, prevention, and monitoring. So you really can go to the guidelines that's available online for free and look up whatever it is, with ICIs or CAR T or anything else. Most of what's available on the market right now is really covered by the guidelines and see what's recommended. But typically, echo and nitric peptide at baseline. Usually for CAR T, we do get a troponin because we want to have a baseline. It's kind of a common sense. Your patients who have excellent functional capacity coming into CAR T usually do better. There are certain considerations there that we kind of are unique to these patients. So a lot of these, especially malignant hematology patients, will have thrombocytopenia either because of their malignancy or because of the chemotherapy they got before they, were prescribed CAR T. So treating these patients can be a little challenging. If you have somebody with coronary disease, you may not be able to give them antiplatelets. A lot of these patients become neutropenic, so they have HFpEF or HFrEF, and you want them to take an SGLT2 inhibitor. There's really not a lot of safety data on this, so kind of treating them becomes a little bit challenging. Those with severe valve disease, we try to treat them if we don't think the valve assessment, the valve procedural recovery time is not going to put them at an adverse risk of malignancy. So if it's somebody with severe aortic stenosis who has a decent anatomy to have a TAVI and can get back onto the CAR T schedule within a couple of months, maybe their disease is stable, maybe they can afford to wait a couple of months. We try to fix that before we put them through CAR T, because once that ball rolls on CAR T, it's basically a waiting game. Once they come in for the admission, they will have a lot of cytopenias, either because of the CAR T itself or because of the lymphodepletion therapy. So they may become thrombocytopenic and neutropenic for a long time. You're basically stuck. If you have a severe valve disease that you have to treat, you won't be able to do much about it during the recovery period of CAR-T. So we get EKG, natriuretic peptide troponin on most patients, typically get an echocardiogram in those who develop CRS grade 2 or higher at a follow-up visit of 3 months or so. The long-term surveillance for these patients is really not that well defined because it's just a relatively newer technology. So we really don't know much about the long-term cardiac adverse events of these therapies. But we do know that patients with elevated CRS grades need usually more frequent monitoring than those who, let's say, don't get any CRS or just get a CRS grade 1, for example. Okay. When they're admitted here, we typically watch them for arrhythmias. Everybody pretty much monitor the volume status for a lot of reasons. One of them is that when people get these chemotherapies, typically they get a lot of IVF, IV fluids with them. It's just part of the protocol. So if they're coming in here with some HFpEF, then you want to see them pretty much every day, manage their volume status. If you somehow end up in cardiac trouble while thrombocytopenic, it's unfortunately hard to do anything about it. So a CAR-T patient with thrombocytopenia and STEMI, it's really terrible prognosis. There's really little way around it. And this is true not just for CAR-T, for a lot of these other therapies when it comes to cancer. So even bone marrow transplant is the same thing. Those who develop complete heart block, you may be able to do a TVP on them, but again, if their platelets are 5 or 10, then you may have to transfuse platelets. If they're thrombocytopenic, if they're neutropenic, of course, there's a lot of infection precautions there. This is a very big point when it comes to these patients, and it's really the drug-drug interaction. So it's really good to have a friend who is a pharmacist, kind of looks behind you and make sure you're prescribing the right thing, not just because you want, to avoid, of course, cardiac adverse issues, there's interactions, but you really don't want to give a cardiac medicine that will make a cancer drug ineffective or less effective. So really talk to your pharmacist about what you're prescribing for these patients. We monitor all these patients for CRS, and typically the oncologists are very good at doing that. Typically by checking CRP level, ferritin levels on a daily basis. We've learned to become more aggressive in treating this. So with any signs of CRS, our group here typically is aggressive at giving things like tocilizumab, which is an interleukin-6 blocker that has been effective at minimizing the chances of CRS progression, and also helps at preventing cardiac event. There's really good literature that says the sooner you give tocilizumab in patients with CRS, the better the outcomes. And actually, every 12-hour delay in giving tocilizumab in patients with CRS grade 2 or higher led to more cardiac event. A very nice retrospective analysis that was published a couple of years ago. It was a joint effort between Moffitt and Mass General. Okay, so our group really gives it here to earlier grade. And we've published this earlier this year. Once patients receive interleukin-6 earlier on, really the chances of major cardiac events are much less. Yes, we still do see a lot of atrial arrhythmias, but MIs, cardiogenic shocks are much less common when the CRS grades are much lower. Most of these cardiac events happen early. So really, if you have a patient who get their CAR-T on a Friday, I typically ask the fellows to see the patient every day on Saturday and Sunday, because that's usually, it happens pretty early on. And we always remember that acute coronary and cerebral events happen even when the platelets are low. So having platelets of 10,000 or 15,000 is really not protective against ACS or acute strokes or TIAs. It's something about the heightened inflammatory response and the fact that if these patients have any platelets, they're typically large and hyperactive. So just remember to keep that suspicion high, even when there's thrombocytopenia. You may not be able to do much about it, but at least make a diagnosis. Once these therapies are done, typically we try to optimize what was stopped. So if somebody comes in with heart failure on GDMT, typically uh, these GDMTs usually are held in the peri-CAR T period because of either AKI issues or hypotension issues. We're looking into how safe it is to continue some form of GDMT for heart failure patients or statins in patients with CAD, and see if that makes any difference in terms of. So I think in the next year or so, we should have better data. But right now, the protocol typically, and it may be different at your hospital, is to hold most of these therapies for the CAR T to avoid hypotension and CRS. If there is something that we postponed, a valve or a lesion, coronary lesion that was insignificant, or you didn't want to work on it before, you got to wait for cytopenias to improve before you put these patients back on the heart team schedule. And always watch for drug-drug interactions and, of course, QT prolongation monitoring for those with prophylactic antibiotics. And we touched upon this again. Really don't know the long-term cardiac side effects of this, so stay tuned. I know a lot of folks are working to identify this, but this has just become commercial in the last couple of years, so we have a lot to learn there. The patient that we saw, unfortunately, didn't do very well, so we started him on inotropes and vasopressors. He got dexamethasone and tocilizumab for the CRS. His EF, when we saw him the first time, was 10-15% or so. After a week of inotropes and dexamethasone and tocilizumab, it did improve to 50%. Had a long hospital course after that, and unfortunately, eventually passed away from pneumonia and septic shock. That was the first one in a very long time that we had this dramatic course for. It's really nice to learn from the oncologist experience here. But a lot of things that I'm learning from them. Number one is how they approach patients and monitor them throughout their illness, and how aggressive they are in enrolling patients in clinical trial. So typically they have a lot of folks that will look pretty much at every patient who comes into the cancer center here to see what study will this patient be eligible for. And they approach these patients with a lot of, eventually most patients will be eligible for some study, 1 or 2 studies. So it's really learn their experience, and especially when it comes to the CAR T, because we're learning and seeing a lot of promise in terms of CAR T use beyond cancer. So you'll see reports here and there about CAR T cells being used for something else that's not cancer. So one example is diabetes, type 1 diabetes, targeting these autoantibodies, basically to allow these beta cells to flourish and produce insulin. There was a very nice case report here of, I think, 5 or 6 patients with refractory lupus that was published in New England a couple of years ago, who were treated with CAR T. Again, this is investigational CAR T. So basically, these CAR T cells were made to target the lupus receptors on these cells. So CD19 CAR T cells that worked on these particular cells, and patients did very well, at least on the short-term follow-up. And I know there were a couple of talks about HIV. There's another report that I saw a while ago on a patient with sickle cell disease, and a young patient who basically was who did very well after CAR T. This was a very nice Nature paper that looked at inducing fibrosis in mice. So on the left here, kind of summarize the study for you. They gave these mice saline injections. So this is your basically control. Some mice were given angiotensin and phenylephrine to induce fibrosis. And those same mice were given CAR T cells that targeted the fibroblast after a few weeks. And you can see the dramatic difference. Red here is the fibrotic cells, and this is the mice hearts after CAR T. So there's a lot of promise in targeting fibrous tissue in patients. There's nothing that I know of that's close to being come close to the FDA review, but we certainly look forward to this. And I think this is the time to learn how to deal with CAR T complications, because if we're going to use this for other indications other than cancer, we should really be comfortable using tocilizumab, other anti-interleukin inhibitors like anakinra for things like for complications of CAR T. So I think I'm going to have another 15, 20 minutes or so to let you guys ask questions. But basically, conclusions here, you're going to see a lot of immunotherapies thrown around. Indications are expanding. Remember, if you see something that you don't recognize, look it up. See if it's an immune checkpoint inhibitor, because really it makes a difference in terms of how you approach these patients. Most of the events that we see in CAR T and ICIs typically happen because of heightened immune response, and recognition of CRS grade early on really helps you avoid cardiac events. And I hope that kind of got messaged. And if you have any questions, please, I'm all yours. So I think I give you 15 minutes back for questions and comments.
Thank you very much, Dr. Alamar, for very nice coverage. And I think your slides were really speaking of how much involved the field has become in terms of very specific approaches that you have to take. So you have to almost be in that frame of mind, knowing the literature, to be able to take care of patients. So it's really a subspecialty in its evolution. Before I open up to the floor for our panelists to ask a question, my one question is, what does it take for someone to become a cardio oncologist, in your opinion?
Thank you. I did not expect this, but this is great. Actually, the International Cardio Oncology Society has published a document outlining what it is really needed to kind of make a cardio oncologist. It goes from a few months of electives with a cardio oncologist at their rotation. This is really to kind of equip the cardiology fellows really with the right knowledge to go into practice, hopefully into the community, recognize what these cancer therapies do, and implement preventive and treatment strategies. It goes from clinics, basically. That's usually what we do most of our work here, and typically involves a rotation of 2 4 inpatients to do the inpatient cardio oncology emergencies. So the ICI myocarditis, the CAR T CRS, and other cardiac toxicity from immunotherapies. The dedicated cardio oncology fellowships out there are really, I think we have about 10 or 12 programs in the country that offer the fellowship. We have one of them here, and I think we should have more of those to open up these cardio oncology programs around the country, to really not just monitor for cardiotoxicity, but really start to prepare the field for prospective cardio oncology trials like the Atrium, to really have somebody with interest strong enough to sit on the oncology trial boards and design studies to have cardiac adverse events as primary endpoints, instead of just seeing what these chemotherapy drugs showed on basically retrospective analyses, and build programs. It takes, I think, for now, the ICO Society, I think, to sit for the cardio oncology certification, I think you probably need to see 100 or so individual patients with cardio oncology needs, and have somebody sign off on your abilities. But it can be designed, and we have done that for our fellows in the past if they had interest, to bring them back and have them do more. But certainly, I think really should be part of the general cardiology training, to have some dedicated time for cardio oncology, because you're going to see these patients in clinical practice, whether you want to do cardio oncology or not. These patients are living a lot longer right now. They live with metastatic cancer for much longer. So a metastatic disease now would be a 4 or 5 year thing. So patients live long enough, they'll have heart disease. And we know that cancer and cardiovascular disease really share a lot of risk factors. So they have cancer, they'll live long enough, they'll have heart disease. Thank you. You got me very excited about that one. So that was a long-winded answer to your question.
I'll come back to you more for getting you excited even further. But before that, let me just ask Sasha and then maybe Brandon to comment and ask questions. Sasha?
Sorry, I was on mute. Thank you so much, Dr. Alomar, for that talk. Excellent, excellent talk. I have a bunch of questions, but I'm not going to take up too much of the time. The main question on my mind is there a focus now towards like aggressively or more aggressively treating metabolic syndrome in the patients that you're seeing and following up for their possible cardiotoxicities in the clinics? And then how are you doing, how are you doing that? Are you instituting PCSK9 more aggressively, et cetera?
Thank you for the Sasha. Yes, it's one of the things that I get yelled at a lot for doing. So a patient with, what I tell patients typically, they come in, maybe they're on a VEGF inhibitor, they've been on it for a year or two. Their oncologists are nice enough, smart enough to recognize that they need to see you for metabolic syndrome management, and maybe they have an LDL of 110 or so, mid 50s, and they'll tell you, well, my primary care said it's really not too bad, just eat some vegetables. And what we don't know is that these patients it's a different animal. These toxicities are different, these drugs are different. Most of the risk factor scores that we have, and I tried to do this, the 10-year ACV risk derivation cohort, I went into the studies and literally controlled F the document to see if there was any cancer patients and how much. They're really underrepresented in all of these. So when somebody comes in with a quote-unquote low risk for atherosclerotic disease, for example, I'll try to tell them, I don't think that's true. At least we don't know if that's true. And I push for aggressive risk factor modifications. Statins, of course, are the first one to do. And we're kind of seeing some data right now that's not just only for primary prevention, but we know that patients with, let's say, lymphoma and anthracyclines, having statin prevents cardiotoxicity, so heart failure cardiotoxicity. We will be looking at this with other things like PCSK9. Same thing with HFpEF and heart failure and SGLT2is. There's a lot of push right there to start these therapies for patients earlier on, because it's just their risk is not the same. Having cancer is really kind of modifies and heightens your risk factors for CAD and other diseases.
Brandon?
Sure. Thank you again for the talk. One question I had is, we know that the immune checkpoint inhibitors, typically, if they're going to induce myocarditis, typically occurs about a month, as you had mentioned, after therapy. Do you tend to have closer follow-up or more screening around this time where you'd expect the myocarditis to occur if it's going to do so?
Very good question. And I think that's really one of the biggest challenges we have in this is who to screen and when is it too much testing? Because the very last thing I want is to send somebody for a troponin that comes back slightly positive and have their oncologist hold their next cycle because of fear. So typically for those with normal baseline troponin BNP and no symptoms, no EKG changes, we typically try not to order troponins on just for that, because we know that it's not very common. We know that excessive testing can lead to treatment interruption. But those who have asymptomatic elevation in troponin either before the first cycle or after, if there's some concern for EKG changes or for other reasons, then those we do screen a little more frequently. So typically, what we do for these patients is to get a troponin and preferably high sensitivity troponin I or T before their next cycle. So typically, if it's every 2 weeks or every 3 weeks, and usually have somebody call us with the results. we still haven't figured out exactly what to do if it's just a little bit high, or if it goes by 5 or 10% increase, for example, asymptomatic, no EKG changes. If there's, of course, any concerns for symptoms, we send them for an MRI and make a diagnosis and withhold the therapy. But I don't think we have really good recommendations in terms of what to do if the troponin remains flat or goes up by a hair, goes down by a hair. My recommendations typically have been, if patients are asymptomatic, they're willing to take the risk of progression to immune checkpoint myocarditis, then I usually let them have it and have them come back after 3 weeks for a follow-up. But it's really hard to tell how to do this right now. We don't have a lot of guidance.
All right, so so in your practice, so I'm going to be again asking you very basic questions. How much cardio oncology do you need to do, and what happens to general cardiology?
Yeah. So I think it's you don't want to lose, of course, the forest for the tree. So you still want to. In practice here, when it comes to cancer center and for a place like yours where you have a NCI designated cancer center, you have to have that program that does at least 80% of their clinic volume for cardio oncology, directed at cardio oncology. In the community, I think what I found most helpful for the community cardio oncologists is basically have that relationship with the oncologist in the nearby clinics and save some 10% of your volume there. It's really about how to allow these patients to continue getting their chemotherapy without getting in the way. So I try to avoid the over testing, and usually those patients who will require our input is usually 10 to 20% of those cancer patients, at least from the register that we've seen. We're talking about cancer, there are millions of them that usually will fill your clinic. So if you're gonna ask the oncologist to send you patients, just make sure you have the right staffing to do it, because really it's kind of open the floodgates before they start sending the next one.
Yeah, and as the population is aging and the prevalence of cancer and cardiac diseases are commonly increasing, and as people are surviving through the cancer therapies, I think the bigger problem becomes other host of cardiovascular diseases with AFib and coronary artery disease, that, and also with aging population, valvular heart disease. So I think the future is going to be very interesting, because you have a world of that is colliding with heart failure, AFib, and cancer together, and that's what the population above 65 is going to be. So I think each one of us is going to be probably facing the same cohorts of patients.
You're absolutely right. Yes, I always tell patients, and the oncologists here, if they've been in practice long enough, they'll tell you 20 years ago, patients didn't live long enough to have a lot of heart disease. But with all of these immunotherapies, the oral tyrosine kinase inhibitors, that's a pill that keeps patients basically living for years, they'll live long enough to come to your practice. So I think we should really start getting familiar with all this stuff and how they're pronounced and what they do and who to call when something bad happens. Absolutely.
Any more questions? One, maybe a quick one. Any of you, Sasha or Brandon, want to go for him? No burning questions. All right. Yes.
This is Yasmin Hamarani with the cardiologist, Dr. Almari. Very interesting backgrounds. Thanks for your time. A quick question in regards to imaging. I know you didn't focus too much on doxorubicin and maybe the cardiomyopathy, but in cardio-onc population, we hear that these patients in acute settings when they're sick, and you're looking at EF assessment, and you're trying to decide whether you want to do an echo or an MRI or a MUGA scan. Now we hear a lot that MUGA scans are coming back because they are quicker. You're looking for ejection fraction only. The patient is sick and for EF. So what kind of imaging modality do you prefer to use in these patients? Thank you.
Thank you, Yasmin. Yeah, thanks for the question. I can't tell you the last time I ordered a MUGA on a patient, and typically it usually comes from an older oncologist who's been familiar and just comfortable looking at MAGA scans. I try to, with our SOPs here, we try to favor echocardiogram for everybody. And I try to kind of, every opportunity I have, whether it's grand rounds for oncologists here or meetings, like remember we have the echocardiogram here that will see much more than just an ejection fraction. And even, of course, you're familiar with these patients, so they're kind of a tougher patients to get. The image quality may not be the best. Even when that happens, if I can't get an echocardiogram that's good quality, I'll get an MRI if I before I order a MAGA scan. So usually they'll have to twist my arm on a MAGA there, especially with anthracyclines. Anthracycline patients. So we're talking about breast and lymphoma. Okay, so that's tons of patients that are going to come and see coming from the cancer center. With guidelines being established right now, everybody's going to be able to read and send patients. Typically, for these patients, you get an echo at baseline, echo at completion of therapy, echo at 6 months, echo at 1 year. This is kind of a recommended algorithm. So if an ejection fraction assessment is done by a MAGA with all these intervals, that's tons of radiation. I think it's really unnecessary for, especially these younger breast cancer women or those sarcoma survivors who usually have tons of anthracycline. So on an average, lymphoma patient will get 300 milligram per square meter. It's a lot of anthracycline. So we really need that EF assessment. So just, I think it requires a lot of like gentle reminders, like we have this technology that's safer and better and gives us more information than the MAGA. But yeah, good question. Every now and then I'll get a message about what do I think about this MAGA. Like, God, why was this ordered in the first place? But a lot of tender love and care, I think, feedback.
Great. Thank you very much. Very exciting. I think this field is going to continue to grow, and we look forward to learning more and more. And thank you very much for staying so late. And we look forward to your contributions in the future. It's
been a pleasure. Thank you for the invitation, everybody, and I hope you hear from you. If you have any questions, please feel free to email me or Twitter. That's usually the way to go around these days, right? Social media. Social media, absolutely. Great. Good night, and
good night. Bye-bye.